Maya, how are you?
Good. How are you?
Good, thank you. Just I think perhaps because I didn't send an email out, nobody seems, we got a few people.
I let them know.
Wait another 30 seconds and get going. All right, why don't we move forward? Okay, so this is a 3-month-old who had an AV canal repair, and this is post-op hour 3. And this is the patient's spontaneous rhythm. So why don't we see, Molly, what do you think's going on here in this patient?
Good morning. Let's see. So looking at the left of the lead 2 is sticking out to me, where you're seeing the QRS and then what looks like either your T and U wave, or is that a P wave? Because then when I go to the next QRS, I'm not seeing anything before that.
Uh-huh. Yep.
And then as you continue on, then towards the end of the screen, you see a little bit, like towards about 2/3 of the way through or so, you kind of see that continued trend. Yep. And then you see that the QRS widens a little bit, and then appears to pick up. Again, doesn't appear to be, to me, concerning that it's not sinus, but then also seeing like a widening of the QRS as well. And a little irregular in the rate too.
Mm-hmm. What do you make of the relationship of the P waves and the QRSs, and particularly in these beats here?
I don't think they're related. They're a dissociation, I think.
There's dissociation, right? So what do you think this is, and what do you think this is? Are they the same thing, or versions of the same thing?
I think I think they may be different versions of the same thing, with the beginning appearing maybe to be like a junctional, and then becoming more like junctional, like jet towards the end versus VT at the end.
Mm-hmm.
Would like to do like an atrial electrogram to further confirm that, but you can kind of see the P waves there too. But
right, so you don't really need the atrial electrogram, right? Because you kind of figured it out without it. So yeah, I agree that that was outstanding. Very good, Molly. So we're looking on the left-hand side of the screen. We see, just like you pointed out, I'm pointing here in lead 2 to some upright P waves that seem to be following the QRS. I think we can, with reasonable certainty, know that this P wave is not conducting to that QRS, because the ventricle hasn't even repolarized yet. So this is like some kind of a junctional rhythm with a slightly slower sinus rhythm, and then the patient starts developing tachycardia at a little bit slower than 150 beats per minute, maybe about 150 beats per minute, and there is ventriculoatrial dissociation. And I agree with you, and this is an interesting point, which is that although the axis of all of the QRSs and the complex morphology is very similar to what we believe to be junctional rhythm. In fact, it is not exactly the same. It is wider. And so formally, I think we would say that this is a ventricular tachycardia rather than jet. Although practically, in terms of how one would manage this, it would probably be similar, because the same therapies that would work for junctional ectopic tachycardia would also be effective for the treatment of jet. Now, so Christina, if you saw this rhythm and you saw this patient and, post-op hour 3, we want excellent cardiac output. So this, I think we'd all agree, this heart rate is too slow. This heart rate is, this dissociated faster rhythm. The rate might be okay, but the rhythm not so much. So how might you treat this, do you think?
You can pace this patient.
Pace, okay, I agree with that statement, but I'd like a little more detail in the answer.
So it's a 3-month-old. You can pace them to 140 beats
So you're
per
saying
minute.
basically pace a little faster than the fast rhythm. But I guess my question is, are you pacing in the atrium, in the ventricle, or both?
Would you pace in both?
Well, you could pace in both. And, without meaning too much disrespect or poking too much at our anesthesia colleagues, that's what they would usually do in the operating room. But in truth, you could just pace the atrium, right? And see if you conduct, because now we're saying this is probably VT because the QRS is wider than these beats. If you were to pace the atrium at a rate faster than this rhythm, let's say just for the sake of conversation, that this R to R interval is roughly 150 beats per minute. So you decide you're going to pace at 160. If you paced and you were conducting 1-to-1, would the QRS look like this, or would it look like this?
It would look like to the right.
This morphology?
Yes.
Well, you had a 50-50 shot. This time we're wrong. No, it would look more like this, right? Because if this is junctional rhythm, right, it's arising from the bundle of His or the AV node. So when you're in jet, the QRS morphology should look pretty much exactly like it does in sinus rhythm. Whereas when you're in VT, it does not. So we would expect that if you pace the atrium at, say, 160, that you would actually see this morphology of QRS, not this one. You would basically suppress the VT by conducting down the AV node. Does that make sense?
Yes. Thank you.
Okay. Now, what practically happens, unfortunately, is so you could pace the atrium and pace faster. But what happens often is that either because someone in the operating room or even after the operating room in the ICU gave amiodarone or some kind of an antiarrhythmic agent, what can happen is that you can have AV block, or the AV node doesn't conduct very well. We know there's not AV block, but there could, well, we don't really know, but probably there is not AV block. But what can happen is that giving something like amiodarone can slow AV conduction, so that maybe you can only conduct up to a rate of, say, 150. And so if you pace at 160, you might wanky block or have 2-to-1 or something like that. So it may be that the only way you can pace this patient practically is to have AV pacing. But initially, we would generally want to pace from the atrium and not the A and the V, because most patients conducting through your AV node will result in a more organized and improved ventricular contraction because of the degree of synchrony that conducting through your normal bundle branches confers on most patients. And that's not 100% true in everybody, particularly if you have like a left bundle after surgery or something like that. But definitely we would try A-pacing in order to see if we could have conduction through the node and how our output would be. So, and then of course we would want to treat the arrhythmia, which, so if you saw this arrhythmia, let's go back to Molly, what medications could you consider trying to quell this arrhythmia? Molly?
Sorry, can you hear me now? My headphones are going out of me, so I keep having to switch out back to my phone. Can you hear me now?
Very well.
Okay. You could do either procainamide or amiodarone.
Mm-hmm. Now remember that we think this is at least a formally VT. So, but Proc is a very reasonable agent for VT also. So both of them are reasonable. You all know I have a little bit of a tendency towards Proc, but amio perfectly acceptable, very reasonable option in this type of circumstance. You could also, some might even say that it's not unreasonable to just pace and not start an agent and just wait it out, because most of these postoperative arrhythmias are self-terminating. I don't think most of us would do that on the theory that it would get worse. If you're only in post-op hour 3, the tachycardia could accelerate. So probably we would not do that. We would actually not only pace, but we would additionally treat with an antiarrhythmic agent. Okay, good job, everyone. All righty. So this is a tracing from an infant who was identified to have an irregular heartbeat in the well baby nursery and was brought to the neonatal ICU, and this is the rhythm that is observed. So why don't we go to Dr. Kalis and see what she thinks we're looking at here.
All right, so it looks like we have what looks like a sinus rhythm, but then with a bunch of beats of what looks like VT. Looks like there's a triplet, there's like maybe a PVC, and then there's kind of a longer run afterwards.
Mm-hmm.
And you're saying this was a well baby, the well baby nursery?
Well, the rhythm was heard in the well baby, but this was recorded in the NICU after the baby was transferred. Right. So I agree. This is some kind of VT. So, okay, so you see this on an EKG. How would you evaluate this patient, Maya? Like what would be involved in the evaluation and then potential treatment of this?
I think so. I guess the first thing I would think about is accelerated ventricular rhythm of the newborn, given the history. And I think this is something that is generally benign and resolves. But I think just given that we have seen this abnormal rhythm, I would probably do an echo on the kid just to make sure we're not missing anything. And then,
well, what would you be looking for in the echo? I agree. I think we always would do an echo, pretty much anything in cardiology. But what would you be looking for? Why, the Alan, you call Alan the tech and say, Alan, I need you to do an echo. Can you do one? He says, sure, doc. What am I looking for, Maya?
I guess making sure there's no like cardiomyopathy or anything else that could be leading to VT or ventricular arrhythmias.
Right. So you could have cardiomyopathy that causes VT, although honestly, that's pretty unusual in newborns, right? I'm not sure I've ever seen that, but I guess it's possible. But it's also possible that the VT, right, can cause cardiomyopathy, right? If you're in tachycardia a lot of the time, right, we know that you can get a tachycardia-induced cardiomyopathy. So whether the chicken comes before the egg or the other way around, you'd want to know what the function of the patient's heart is. And let's say, for the sake of discussion, it was normal. Is there anything else you might want to see on an echo?
Make sure there's no like rhabdomyomas or like.
Yeah, that's a great idea, because that definitely can cause ventricular arrhythmia. Rhabdos are notorious for doing that. Can cause atrial arrhythmias also. Let's assume, for the sake of discussion, that's not the case. But let's just, for interest, since you brought up rhabdos, what's the natural history of that with the rhabdos? If it were a rhabdo.
I think I think those resolve.
Yeah, well, they may not fully resolve, but they often will get a lot smaller, if not completely resolve. So, so we would, be cautiously optimistic that patient who had arrhythmia from rhabdos, that the arrhythmia would improve as the rhabdos got smaller over the first 2 years of life. Any other conditions that could cause VT in a baby? So there's this, I've not actually seen this, although I should say maybe I've seen it, but I didn't know I was looking at it. But the group in Texas, particularly, a very big, have written a lot on the concept of Purkinje cell tumors, like LV Purkinje tumors that can cause VT. I think these can be seen when person has them. I think it's been described as being seen mostly on MRI, but I think it can be seen on echo. I've not actually heard of it being identified in any patient I've taken care of. But again, it's possible that I didn't know what I was looking at, or people who were echoing weren't aware of it, or I don't know, honestly. But so, the decision about whether to treat this, normally I would agree with you, Maya, that we would generally not treat ventricular ectopy in a newborn if it was hemodynamically tolerated. But when you're seeing runs this fast, right, these numbers on top of the QRS complexes presumably are the cycle lengths or the R to R intervals. So if we're getting down to 272, right, that means that the heart rate is above 200 beats per minute on some of these beats. So I guess the decision, here's 255, so close to 240 to 250 beats per minute. So, it's there is no hard and fast rule about this, but what I would say is we would observe this and observe the frequency, the rates, and then determine how we might want to treat this, if we need to treat it at all. In other words, if this panel was the only panel of a 24 or 48-hour period, and that everything else was just occasional single PVCs, I might be inclined to observe and not treat. But if this type of, relatively fast wide complex tachycardia occurred all the time or very frequently, then I might be more inclined to treat it. On the theory that if this were to become more prevalent in an individual patient, they might develop myopathy or something like that at home. So if you were going to treat this, Maya, what would be your first line? What would be the options you would have to treat this with, I should say?
So I guess with VT, I think of using drugs like procainamide, amio.
Well, let's say the patient is clinically stable, so you feel comfortable using an oral agent. So proc is out, right? Because it doesn't come as an agent that can be given orally to babies.
Okay.
It's a reasonable choice IV emergently or urgently, but it's not an agent, unfortunately, to be given. Not only, I mean, it can be given to babies. The problem is the half-life is very, very, very short. It's like literally like 2 or 3 hours. So you have to give it like every 4 to 6 hours. So it's not practically possible to give proc to babies. So as an oral agent. So proc's out, but you said amio. Yeah, amio could certainly be given. And what would be the daily dose to treat VT if you were using amio for VT?
VT, so so we often start with 5 per kilo, but I think that might be with SVT. I'm not sure if the VT dosing is different.
It is. It's a good point. That's the reason I asked the question. So you're right. Most of the time you see us treating with people with 5 per kilo per day because we're treating usually supraventricular tachycardias, whether it's regular SVT like ORT or AVNRT, or whether it's EAT or any number of SVTs, we would treat with 5 per kilo per day. But for VT, the traditional treatment is 10 milligrams per kilogram per day. So you should always remember that. And, when you're treating, always make sure you use the higher dose for VT. Okay, so that would be one option, amio. Advantage of that is eventually the patient would only have to take it once a day. And in a lot of countries, it's actually very easy to get amiodarone, and compliance is improved because it's once a day dosing, obviously associated with lots of potential side effects. But for short-term therapy, particularly with a disease where we think that it is going to self-resolve, it's a very reasonable option. What else could you try? So that's a very good idea. Any other options?
The other one I think of is lidocaine, but I think that one's also IV.
That is correct. There is no oral lidocaine, but there is an agent that works similarly that is oral.
I think it's like flecainide.
No, flecainide is a class 1 agent, but it's a different category, right?
Mexilatine?
Yeah, mexilatine is in the same category as lidocaine. One could use mexilatine, but I don't know this literature, but I believe that in studies on adults, it works reasonably well to suppress ventricular activity, but like on average, people don't live any longer. It doesn't actually prevent sudden death or anything like that. So mexilatine is not unreasonable, but usually you would pair that with something else, just because we don't have confidence that it is by itself for this type of an indication adequate. Dr. Walsh, who's one of my mentors, used to say mexilatine's great at fixing Holters, not so good at fixing people. And I think by that he meant that you could really profoundly reduce the amount of ectopy with it, but it may not, if you're worried about something that's potentially life-threatening, it may not be of benefit that way. What else could we try?
I guess you could do a beta blocker.
Yeah, you could use propranolol just like you do with almost any other arrhythmia, and we have a long track record of safety with that. Again, as in all arrhythmias that we treat, we don't really know if it'll be effective. It'll be trial and error to some degree, but it's not unreasonable to consider trying a beta blocker. And by the way, you mentioned flecainide. Some people would use flecainide for ventricular arrhythmias. I personally do not usually treat ventricular arrhythmias with flecainide, mostly because of its pro-arrhythmic potential, and my concern that if the function were depressed, I'm not sure I want to use that. It also is a bit of a negative inotrope as well. Hard to administer. We've talked in the past about how often dosing errors occur with flecainide. It's hard to give to babies properly because it has to be in a compound, and compounds aren't very stable, etc. Hard to mix it. So no, I wouldn't be a huge fan of flecainide for this, but there are definitely electrophysiologists who would use that. Another option, right, could be sotalol, right? You could use sotalol, which is also a good antiarrhythmic agent. That's both a class 3 agent as well as a beta blocker in combination. Also comes as a solution commercially, and it's called Sotalize, which I believe is like 5 milligrams per ml or something like that. So you can order that at a pharmacy. It doesn't have to be compounded. So those are some of the options one could use. And typically what we would do is start it. If the ectopy becomes a lot better, we would watch this patient as an outpatient with exams, a couple of echoes here and there, a few Holter monitors or Zeos or Barty devices, and then hopefully over time it would improve and we'd be able to come off agent and not have VT anymore or have markedly reduced VT. Any questions about that? Okay. All righty. So this is a tracing from an old book that I had. One of my former colleagues retired, and he said I could take any of the books in his office. So I took this book that had this tracing. This is an intracardiac tracing. And so just for all of us, these are the 1, 2, 3, 4, 5 ECG leads. I'm sorry, 6 with V6. I don't know why there's extra space between these. high RA, His. There's only a single channel. You know that when we do cases, usually we have 3 channels and then an RV channel. And of course, there's no lines on this paper. We're going probably at like 200 paper speed here. And so the person who interprets this for us is telling us that the AH is 130 milliseconds and the HV is 95 milliseconds. So the author of this slide said, what is wrong here? What's wrong here? So why don't we ask Dr. Candid what she thinks about this?
Good morning.
Good morning.
Okay. Okay, so if I'm looking at the did you say that's the His that
yeah, the thing that says HBE, of course you can't see the first letter. It's His bundle electrogram.
So
and they've obviously telling us the AH and the HV because you don't have calipers on this screen, and the author of this question wants you to know those data. Maybe part of the answer to the question.
Yeah. So when I'm looking at the intracardiac tracing, we're seeing an like it's labeled, there's an A and a V, but if we look at the surface electrogram, it just looks like there's just the QRS complexes.
Well,
or is it little tiny? Okay, yeah, gotcha.
So, again, if you remember, everything's all running at the same time simultaneously. So this is the A. So if you look up here, right, you could imagine, right, that there's a P wave here. It's not, for whatever reason, the ECG is not amplified adequately in this tracing, but this is clearly a P wave.
Okay.
And what do you make of this P to QRS interval?
It's like the upper end of normal. It's long.
It's long. Now, it's hard to tell, of course, because the paper speed is fast. There's no lines on the page. It's kind of an unfair question by me. But, I think even though the QRS is strange looking because it's being run at such a fast paper speed, I think we would agree that this is a long PR interval for someone whose QRS is this wide. In other words, it's long. Yeah. So there's first degree heart block here.
Okay.
So the question then is, are these normal values, the AH and the HV?
I think both are long.
Okay, so what would a normal AH interval range be, and what would a normal HV interval range?
I think normal HV is in the 50s rather than the 90s.
Yeah, so you're right. A normal HV would be like 35 to 50 milliseconds usually.
Yeah, and then a normal AH is like 50 to 100. I thought like 120-ish would be.
Well, I think you're right that, normally it would be up to there, but officially I think most books will say it's about 50 to 150.
Oh, okay.
But you're right. I mean, 120 is probably like for an adult. I guess I don't know exactly, but I would imagine that if you averaged all healthy adults, probably the AH interval is about 120, 100 to 120. But the range can be anywhere between about 50 and 150. So the AH is sort of top normal, but the HV, as you rightly point out, is long, right? Because the upper limits is about 50 to 55 milliseconds. So what does the HV interval typically represent for us? Is it the AV node conduction or the His Purkinje?
The His Purkinje.
Right. Yeah. So the AH, remember that we can't actually record the AV node on an intracardiac EP study, not with standard catheters. So we record the atrial electrogram at the low right atrium close to the AV node, and we record the His bundle, and we infer that this interval going from the low right atrium to the His is the conduction through the AV node. And then from the His to the V is the His Purkinje system conduction. And so this would be infrahisian disease. And I would remind everyone that infrahisian disease is what we think is usually what's at factor during surgery. So when a patient has remember that the number one cause of block in patients who've had, in children in general, is surgical trauma of all the causes of heart block. And when we do EP studies on these patients, it's not uncommon that the block is at the His-Purkinje system, which is a higher degree of block, a more dangerous degree of block. And I'll just show you in this tracing, we see here the AHV, AH is fixed, but the HV is very long. And then here we have an AH and no V, and then another AH and no V. So this is a very nice intracardiac example of infrahissian block, or high-grade AV block. So this would be like Mobitz 2 heart block on an intracardiac tracing, because the AH is fairly normal in length, but we're seeing an A, an H, and no V, right? Notice in the surface electrocardiogram, no V. So we have a P wave that's sort of buried in here, but we don't have a QRS for 2 beats. So this is very worrisome. And the person who wrote this question is showing that the AH interval is 50. So that's a normal AH interval, but the HV is obviously infinite because it's not conducting on these 2 beats. So this would be an example of infrahissian block. This is what we think is happening when you see a patient who has either complete heart block or Mobitz 2 block following open heart surgery. This would get us nervous for possibility of needing a pacemaker. And this is the most common type of injury we see after heart surgery. Okay, I think with that, I'm going to stop for today. Any questions about that? Nope. Okay. All right, guys, thanks for joining. Have a great day. I'll see you in the cath lab in a little bit.
Thank you.
Thanks, guys.